Well, thank you very much and welcome. Welcome to this evening's talk. And I'm going to talk to you tonight, as we said, about endodontic pain management. I'm Giles, and a little bit about me. I qualified in 1999 from Birmingham Dental School. I did an MPhil in endodontics from Birmingham Dental School in 2011. I've done an Eastman certificate in endodontics. I taught at Birmingham Dental School and lecture on a number of topics. And a number of courses up and down the country. And I run a referral practice, and I'm there 4 days a week at LHDP Smilecare in Bromsgrove, Worcestershire. Well, today we're going to talk about pain management, and I've sort of split this into a few sections. The first section is patient presentation and diagnosis, and that's basically how the patient presents to us, and it's basically what is their complaint, and using all the information that we get to reach that diagnosis. And I feel it's one of the most important aspects of pain management, and we're going to discuss that in quite a lot of detail as we go through. The second section I'm going to talk about is pain management during treatment, and this is, we're looking at how we deal with the pain that the patient's actually physically in at the time. So we're going to discuss things like local anesthetics, we're going to discuss treatments that we can do to alleviate the pain. Sort of things that we're thinking about here is extirpation, drainage, and actually we're going to talk a little bit about pulpotomy as well. And we're going to discuss when we might do each of these things. And then the third section we're going to talk about is patients in pain between and after treatment, and why has this happened? What have we done during our procedure which may have caused this, and therefore what can we do to avoid this in the first place? And then we're going to discuss how we sort of deal with it when it occurs. Well, we're going to start with basically the presentation of patient presentation and diagnosis. And the patient normally presents to us due to inflammation or infection of the pulp and or the periodontal tissues. And the information that we get from our patient gives us an idea of the diagnosis. Well, the good news for us is that those pulps that are inflamed react differently. And we use this to interpret what state the pulp's in and then decide what intervention we need to do. But our patients also respond differently to pain. They've got different thresholds. And we know that pain has it's a number of different inputs. The definition of pain is basically, it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of tissue damage. And some patients, as we know, are just more sensitized to it than others. And some will have a more sort of extreme reaction to it. Well, one of the first questions is basically, why does that pain occur in the pulp? Well, the main reason for it is that really, in truth, the pulp's got a very limited and a very poor circulation. It's enclosed in a very sort of rigid case. And what tends to happen is, as you get inflammation, the pulp tries to swell and it's then contained and constricted. So basically it gets strangled and then obviously then dies off. So the aim of treatment is basically to get rid of that inflammation or infection that's giving rise to those symptoms. And the aim of the treatment also is to aid subsequent treatment that we're going to do. One of the problems with emergency treatment is we tend to rush things a little bit. And often things that we can do can hinder what we're going to do further on. And we mustn't sort of lose sight of the long-term goals. And we're going to cover that a little bit later on. And it's the long-term goals for the tooth, and consider that when we're doing any treatment, basically. So when the patient presents in pain, it's often a difficult situation. It's often stressful, not just for the patient, but also for us. The patient's anxious, and that anxiety can lead to sort of further problems for us, thinking about things like anesthetics, and it makes it more difficult to manage. But also, we know that emergency patients are not necessarily booked when we want them to be. They're either booked across other patients, they're booked around lunchtime, and there often isn't the time to do the treatment that we want to do. We know it'll take longer than we've got. The patient's stressed, we're a bit stressed, we put an anesthetic in and the anesthetic doesn't necessarily work quickly, so it takes longer. So it's not a great appointment for kind of us or them. And the other problem with pain appointments is decisions that we take at the start with endodontics. Most of them have got to be taken at the start of treatment. So we've got to spend time getting those sort of those decisions right. There's a lot of information. Think about things like, do we do a full extirpate, or do we just do a simple sort of pulpotomy at that time? And think about, have we got other treatment methods that we might use? So we've got to think about surgery versus normal orthograde treatments. And all this takes time, but it depends on basically taking a really good history and doing good planning, basically. And this is also part of your sort of consent. For me, consent is a written consent and them sort of signing their consent form. But we've got to discuss everything. We've got to discuss the advantages and disadvantages. We've got to discuss success rates. We've got to discuss all the options, all the sort of, you know, do we take the tooth out? Do we do endodontics? What are the other options? Talk about implants, all those other things that we need to do. What further treatments would be needed? You know, do we need a crown? All these things have got to be talked about before we start our treatment. And it's vital that we do that, because otherwise we're going to get letters from, you know, nice people like the DLP. So good management of patients is about reaching a sort of a correct diagnosis and doing good treatment planning. So we've got to reach the correct diagnosis and implement the correct treatment, basically. We've said before that these patients turn up normally when we're busy, and we tend to get some inappropriate appointments booked in our books. But this is where your staff come in really important. And this is where staff training is really important. And if you can train your staff to know what these patients might need, train them to know the simple, you know, is it going to be an irreversible pulpitis? Train them to ask little questions such as, you know, have you had treatment on that tooth before? And this can tell us if it's, you know, often the patient might know, yes, I had a root treatment on that tooth. You might then think, well, he's not going to open it up and take all the GP out at that point, but that might be more appropriate for for some antibiotics. So it might need a shorter appointment. It's just a case of trying to do some sort of some planning and getting the staff to help you, basically. It's not a perfect system. And you know, but it can help. Like I say, it's not ideal. One of the main problems is that we tend to make assumptions during sort of these kind of rushed appointments. We tend to jump into a diagnosis before you've necessarily done all the tests. You sort of assume that that patient has got, you know, the one that you sort of looks like a classic irreversible pulpitis is there because it's an irreversible pulpitis. So you tend to start your treatment without necessarily taking the full history and getting all the information that you need. And we actually need to be mindful of other causes of dental pain and consider these before necessarily you jump in to do that. And this is basically taking your time to ask all the questions, and it'll save you a lot of time later. And it's a question of improving the predictability, really, of your treatments. Predictability is something that I sort of go on about quite a lot. And what we're talking about with predictability is ones which therefore have a higher success rate. And that's down to good planning and good diagnosis. But to do that, we need to understand the disease process. And you need to understand the role and progression of bacteria. So that's one thing we're going to talk about quite a bit. We need to know not necessarily progression, but where they are in the pulp, because that's going to necessarily change what we're doing. And this will help you to decide what treatment you need to do, if you need to do any treatment, because you might not need to. It also gives you the ability to talk to your patient. It gives the ability to sort of let them sort of know what's going to happen next. And it also feeds back into the sort of consent discussion that we had a minute ago. Oh yeah, it's also going to help prevent misdiagnosis, but it's basically do those tests. And the next thing I'm going to talk about is just the key questions. These are questions that I ask every time. And these key questions are, why is the patient there? Why is this patient presenting to me? What has caused the pain that they're in? And we need to understand that, you know, what's happened inside the tooth. Is it an inflammatory pain? Is it an infection-based pain? And this can change our management approach. And we're going to discuss that quite a lot in a bit more detail. So we're going to talk now about sort of the etiology of it. Well, if it's an endodontic problem, we're talking about bacteria. There's lots of studies out there that have proven the role of bacteria, thinking to the sort of the Kakahashi 1965 study, and that was basically where they had germ-free and normal mice, and what they basically did was expose the pulps. And if they were germ-free mice, you got dentine bridges and you got no abscess formation. And the ones that had bacteria present got abscess formation. So this was a classic study that proved the role of bacteria in the apical infections that were there. But how have those bacteria got in? One of the main reasons are those lovely grey fillings that we see, so microleakage. And there's lots of other reasons, caries, fracture, other things that we might do, so iatrogenic thing. But most commonly is microleakage. And it's very important to consider where they are in the pulp. So if they're just coronal, or if they're further into the tooth and sort of in the sort of more difficult to get to areas, and that can influence what treatments we do. And that understandably affects the prognosis of the treatment. With the early pain, what we think of as a reversible pulpitis. Well, I was always taught to give the pulp a chance, and that was always how how we were taught to do things, to give the pulp a chance to heal. Now the pulp isn't very good at healing, but give it a chance. So the first thing you might do is take the filling out and try, but then it may progress. But what you've got to understand is what's happening is it's bacteria and they're migrating and they're causing microabscess formation in the pulp. And as those symptoms progress, the bacteria are getting further into the pulp and they're migrating apically. They're going into the areas that are more difficult to get to. And this influences our success rates. Coronal bacteria, they're nice and easy to get to. So those are the ones that we can wash out really, really easily in the coronal part of the tooth. But as they progress down and migrate, those areas are more difficult to get to. If we know we've got a long-standing infection, then we've got more strains of bacteria in a more difficult to get to area. And that directly relates to the symptoms that we've got. Reversible pulpitis are caused by the coronal bacteria. Then as that inflammation progresses, you get edema formation. Well, that gives us the tenderness. And as it progresses, you get a more pronounced prolonged ache. That's the sort of the C fiber in nature pain. And it's then more reversible. And this is where those bacteria progress in, is getting more of those into the pulp. And then they progress and you get pus formation, you get more tenderness. And those bacteria are then going to escape through the end of the root and into the tissue. And then possibly you get your systemic symptoms. But we need to decide what we're going to do and when. And we can use that information to let your patients know what's going to happen. And also use it in sort of more difficult to get to diagnosis, because sometimes you've got to you've got to let the symptoms develop basically and discuss it with the patient. Sometimes in irreversible pulpitis, you don't know which tooth it is. But an understanding of what's happening in the bacteriology will tell you that what will happen with time is the tooth will become more specific. We know that because the edema formation, the pus escaping out the end will make it so that you will be able to locate that much more than you do when you've got the sort of the irreversible pulpitis symptoms that you've got. So sometimes you just have to say to the patient, I don't know, and sort of give time for the symptoms to then to play out. And in terms of what treatments you do, like I said, if it's a reversible pulpitis, then give the tooth a chance. But if it's irreversible, then we know that it's an inflammatory based pain, so the antibiotics wouldn't be any use. So then we've got to sort of do something. We've got to get in there and extirpate. If you've got a large swelling, then open it, drain it, and dress it. And the last point we're going to talk about a little bit in the later on is, do you need to do a pulpotomy or do you need to do a full RCT? And if you think the bacteria are only in the coronal part, then don't treat all the root canal system. So consider a pulpotomy, but make the patient aware that you may need full RCT later on, and it's a bit less sort of predictable. So I've put here, start simple. I receive a lot of referrals that have had misdiagnosis, and this is normally due to an incomplete history really, and basic tests not being done. My advice is understand the process, think about the bacteria, understand where they are into the pulp, and look for that sort of predictability. So start simple with the information. Make sure you do a vitality test, and that'll unlock a lot of doors for you. And used in conjunction with your PA, you'll work out a lot of diagnosis, but do all the tests. We'll have a look at these in a minute. Take your PA. I always take a new PA, even the ones that have been sent with a good PA from the dentist. A number of times I've taken a PA and it doesn't necessarily agree with the one that they've sent to me. They might have done a bit more treatment. We've found things in roots which people haven't necessarily owned up to, but also there's things like we can see that the apical area might have changed. We can sort of see when it might have been an uncertain diagnosis that it's easier to sort of to get there. So, you know, get an up-to-date picture of what's going on. Perio involvement, your BPE, your perio probe is going to save you a lot of unnecessary treatment. And the reason for that is if we find those sort of narrow wall defects and look on the other side of the tooth as well, then we know that likelihood is that that's a fracture, and therefore, you know, we don't need to be doing endodontic treatment. We might just decide there and then that tooth needs to be removed. But understand what you expect the PA to tell you before you get the PA. You know, how many times you look at a PA and you see more the more you stare at it. You look at the sort of the apical region, you sort of think, is that a bit of widening? Oh yes, it is. And by the time you've looked at it for a few minutes, you're quite convinced there's a large radiolucency there. So think about what you expect it to tell you. Reach a differential diagnosis before you've got the PA in front of you. Know what that PA is sort of telling you and explain it. I use my PA a lot to my patient because they expect you to be able to fix this really, really quickly. They sort of quite expect you to give them some antibiotics, send them off, and their tooth's fixed. But the PA is a good way of you explaining to your patient exactly what's going on and sort of relating the symptoms to sort of you know, the bacteria and where they are and why it's more difficult. And also then that has a sort of a direct input into the next thing, and that's sort of success rates. And then can you restore the tooth? Really important bit, and that's something that you look at right at the start. So this is something that we need to discuss with all our patients, and it's success and failure. In an infected tooth and in a heavily infected tooth, what we know is the bacteria are further through that tooth. They're in more difficult to get to areas. There's more of them, there's more strains of them. And therefore our success rates are going to be less than if we've got one where the bacteria are still coronal. So that affects our success rate. But discuss that with the patient. So is there any obviously difficulty? We look at the case on this sort of bottom case on the bottom right of your screen there. And you might look at that and sort of think, oh, it's a retreatment case. It's not, you know, it might be difficult. But then you might look at it and think, well, it's not been obturated very well, so has it been irrigated very well? And that might give you sort of more of a predictability than the sort of the one where it's been done by the world's best endodontist and it sort of looks very pretty, and you might say, well, that's not got a very good success rate. Obviously, you don't know how well it's been cleaned, but you know, all these things we've got to sort of got to consider. So can you see reasons for the failure? If you can see a reason for the failure, I saw a patient 2 days ago, and it was an upper one. It had been crowned not that long ago. I would have thought there'd be a periapical radiolucency before it's crowned, but there wasn't a PA taken when it was crowned. And within a year, he's got symptoms. That's quite a predictable treatment because he's had something that's changed the seal on the tooth. So he would got a swelling, so he'd got pain. And now why has he got pain? Well, that tooth had been sealed up, preferably by doing the sort of the nicer crown. And that crown sealed it up really, really well. It's got a nice pressure cooker underneath there. And there was a single point GP that was inside there. So I look at that and I think, well, the perio was fine around the tooth. All right, it's a retreatment case, but I can see a reason why it's happened. So I might look at that and think, well, my success rate actually for that would be really quite high because there's lots of gaps in the obturation. There's lots of bacteria in there. And if, that piece of GP will come out really, really well, it wasn't over-prepared. So that's a more predictable treatment. So in those cases, my success rate is going to be higher. And then it's a question, can you do the treatment? Is it something that you can do? And if you can't, then send it to someone who can. If it's sometimes you can still do the emergency treatment. You can get the patient out of pain. You could get rid of, if it's an irreversible pulpitis, get rid of the coronal pulp, even if it's got sort of, weird anatomy. Medicate and then send it over to your your local endodontist. And if you can't do it, then ring them. Obviously, when we're treating patients, we sort of, we see patients who've got pain. So this is the next bit about the preoperative assessment. So this is just how I do my preoperative assessment and what sort of things I'm looking for when my patient presents to me in pain. I'm looking at the history first of all. I'm looking at radiographs. If I've got any past radiographs, that's great. I'm looking at symptoms past and present. We talked about predictability. Predictability for me, if your patient's had a filling and they've had a filling done 2 years ago and they sort of say, yeah, well, this filling was done a couple of years ago and I got some sensitivity at the time and then the sensitivity's improved, then it's suddenly become more painful. That's a predictable treatment because we can see that the pulp had an irritation a while ago and that the bacteria have developed. If you get the patient who comes in who's had absolutely no treatment on that tooth, it's not had much done to it, and then suddenly it's got an infection around it, then that would ring some alarm bells. So that's the sort of the past and present. Don't just look at the current situation. Look at previous treatments on the tooth. What's been done? How have those bacteria, that we know it's bacterial cause if it's an endodontic cause, so how have those bacteria got in? Look at the previous operator. We might know that some of the operators in our area don't necessarily do the best treatments. We had a couple of people that used to refer to us and they were irrigating with local. Obviously then when their patients come in, we kind of know what's wrong. And then clinically, look at the symptoms, look at the restorative potential. This is something you need to look at absolutely at the start. And we talked a little bit about the perio. Use that perio probe all the way around the tooth. Sort of more than 4 points all the way around. And if you find one of those defects, then have a look on the opposite side of the tooth and look if there's a sort of an opposing sort of pocket, and that would suggest that the tooth is obviously fractured. Look at mobility. Thermal tests, yes. Cold tests, I use EndoWise for that. EPT, I don't use that much. Palpation, yes. Occlusal symptoms, absolutely, and look through those and look at if there's a sinus there. And then other things that we look at complications, access. Can you get in there? Can you do what you need to do? Rubber dam is a complication because if you can't get it on, you shouldn't be doing the treatment. We know that, and it's pretty much indefensible if you don't use rubber dam. Tooth fracture is a complication. It's something that we see quite a lot, and it can mean that it's quite difficult to sort of to access areas that have had infection in them. There's a instrument fracture here is the other thing. This is a case that was referred to me, and basically the dentist had unfortunately fractured the instrument in the tooth, but the patient was in pain. And what we did, I didn't get the instrument out at that first appointment. What we did was we just irrigated it and washed it all out. It was a bacterial cause, and we washed the bacteria out. So that patient, in terms of pain management, we got that patient out of pain. Although it looked at the time, and I didn't even try and get the instrument out at that appointment, because you look and you think, what's happening in this tooth? Well, what's happening in the tooth is it's a bacterial cause. If you can wash those bacteria out, you can flush them all out, then you'll help your patients and get rid of the pain. So that's what we did. Patient factors. Tolerance of treatment, tolerance of the rubber dam. In all the time I've done dentistry, I've had one patient who hasn't been able to tolerate rubber dam. That was it. He physically took the rubber dam off and said, I can't do that, I'm not doing it. And he unfortunately then had to go back and have his tooth taken out. Operator factors. Operator factors, can we do the treatment? Is it something that we can do? So what we're going to do now is we're going to have a look at a couple of cases basically. And this is basically to show, to highlight the sort of the difficulties in diagnosis and how simple ones can help us with the sort of with the diagnosis. And it's just to demonstrate the need to sort of to get all the information that we can to understand why the patient's there, why is that patient in pain. So let's have a look at a couple of cases. This is the first case here. And this patient was kept awake, no difference to painkillers, and the patient couldn't locate or find where the pain was. And the radiograph here shows 3 teeth, and each of those teeth could be the culprit, but each of those teeth would have a different prognosis. The bacteria are in different places dependent on what the diagnosis is. Now, I said before that one of the things that a lot of dentists don't do is do a vitality test. Now, this was a tooth which had been sensitive to hot and cold, and the upper 7 was vital. So it's one of those things that it's just a lesson in do the tests, do the vitality test. Don't sort of assume because of what you see it's necessarily what you think it is. Do all the tests at the time. And this is a case, again, this is one. This patient had a lot of sensitivity to hot and cold, couldn't locate where the problem was, and it was increasing in intensity. Now, to be quite honest here, I couldn't work out what was going on either. I knew it was either the 6 or the 7. Both of them were candidates. They've both got large fillings in there. There was no radiolucency around either tooth. And I couldn't determine which one it was because of the amount of sensitivity. Understanding what happens, we looked at the progression and sort of said, well, what we expect to happen is that it'll become more specific. The tooth will tell us what's going on, and you advise the patient to take some anti-inflammatories and carry on. The nature is normally that these teeth aren't teeth that are in screaming agony. The patient, it's not sort of patient comes in with massive pain and then we send them away and sort of say, come back when it's even more tender. What we're basically saying to the patient is these patients are normally, it's an ache, but it's a controllable ache. And as it gets to the more severe state, normally you can then tell which tooth it is. And in this case here, we sent the patient away. They took some ibuprofen for a few days and then they came back, and it was more obvious because it's, those bacteria have migrated apically and it had got some tenderness there. So, and there it was the 7. And then we got a third case here. And the third case, again, this is, 2 teeth that could be the cause with a different success rate. It could be the 6 or it could be the 7. And again, here we had severe pain, keeping the patient awake at night, couldn't locate it. And in this case, it was the 6. But again, here, both of those teeth, you need to make sure that your history taking is really good, and then you can work out exactly, exactly which is the culprit. I wanted to include a little section here on occlusion. That's partly because I get a lot of occlusal related presentations, and they're often diagnosed as an irreversible pulpitis, and they're diagnosed as an irreversible pulpitis because they present very, very similarly. The only way you'll find out is by taking a good history, because they tend to be very sensitive. They also tend to be tender, but they tend to be sensitive. The pain normally starts in one place and then it kind of moves location. So you'll find that these patients will go back in the history, take your time, and they will often say, well, I had pain that was over this side and then it went over this side. And these patients often have a history of failed RCT because it was occlusal. And you often have patients who have had a number of extractions done, again, because it's occlusal in nature. But a lot of these patients can be quite sure that they know where the pain's coming from. They'll say, no, it's that one. I had a chap that came in to see me recently and he said, I just want that tooth taken out. Now his dentist referred to me because he was unsure about the diagnosis and he wanted me to help him to get the correct diagnosis, because he sort of said, I'm not sure. And this patient said, I just want this tooth taken out and I want someone to take this tooth out. And it's quite difficult sometimes to turn around to this patient, sort of say, no, I'm not going to take that tooth out because it's the wrong treatment. So it can be very, very difficult, but I use little Lucia jigs and I make a little occlusal splint to separate the back teeth. And what I'd said to this chap, as I said, look, I'm not going to take your tooth out, but what I'm going to do is I'm going to make you a little splint and it'll keep the pressure off that tooth and see if the symptoms change. It's almost diagnosing by exclusion. And sure enough, the pain went. and the patient came in and say, I'm really glad you didn't take that tooth out. But it can be very, very difficult. You need to be quite sure of your sort of your treatment planning and your diagnostic skills. So think about other causes. Say they appear endodontic, and you just need to do a good history. Lucia jigs, really, really good. Very easy to make, and can save you a lot of trouble. Restorability, we've discussed this in a little bit ago, and this is something that you need to assess right at the start. When I was teaching at the dental hospital, I used to go over to see students and like, we're trying to restore this tooth. And you'd sort of look at it and you think, well, I can get a root filling in that, but there's nothing I can do with it. I can't actually do anything to restore it afterwards. So it's actually kind of pointless. So do look at the restorability, and that saves unnecessary treatment. We're looking at, here, we're looking at fractures, posts that have got fractures in them, or teeth that have basically not got enough tooth tissue there to restore, or not enough for a ferrule. And these teeth, much as it pains me to say it as an endodontist, but they may be one for those implantologists, and that is a painful thing for an endodontist to say. So here we're moving into sort of into swellings. Now, if a patient presents in pain with a large swelling, then sometimes you can't do endodontic treatment. And one of the problems with that is that you need to do something for the patient. And you need to have a look at the swelling. Is that swelling fluctuant? Obviously, you can't then start injecting local into the area. So in these cases, you need to try and do some sort of drainage. And this is the time when you would actually do some drainage and then put them on some antibiotics and then bring them back later to do the relevant endodontic treatments. You may be able to get some drainage via the root canal. Certainly in these cases, and it's certainly a point worth making, is we mustn't do open drainage. Open drainage basically just leaves a nice big hole which you can stuff a load of bacteria in, which will give us more problems later. So drain it, let it drain, let it drain, let it drain, let the pressure come out of the tooth, calcium hydroxide, and then put some dressing in. So don't, whatever you do, don't do open drainage. In terms of antibiotics, well, bacterial resistance is uncommon, but if the antibiotic, that we are giving them isn't working, then change the antibiotic. Penicillin resistance is increasing. So the second comment is, do an appropriate treatment, get in there and extirpate the tooth. Then you don't need to give them antibiotics. And that's certainly what I would be saying, is, if you don't need to give antibiotics, don't. And where the swelling is normally dependent on where the sort of muscle attachments and things are. So now we're going to go on to the next section, and this is pain management during treatment. I'm going to start with local anaesthetics. And I think that local anaesthetics are such an important part of our sort of our armoury, and it's something that we should be confident about, but often we're not. And that's often because we're not as experienced with doing some of the ID blocks, and they need to be effective. And if they're not effective, we need to have some good strategies to sort of to back this up. So it can be difficult to establish a sort of profound anaesthesia all the time. And most of the time our blocks are going to work, but not all the time. And it's not always us. It's not always our technique. There are other things that can cause problems. You're looking at the level of anxiety for your patient, looking at the amount of pain that they're in beforehand, the cooperation of the patient, the anatomy of the patient, and then the presence of infection or the presence of inflammation. And all these things can influence the sort of the quality of the anaesthetic we can deliver. We also understand about how anxiety causes us problems. And when we're in pain, our bodies are sort of they're basically on high alert, and the threshold for our pain is lowered. And there's also a sort of increased excitability. And one trick that I do is I will use a pre-treatment anti-inflammatory, ibuprofen, for an hour before. And what that does is it puts that threshold back up again. But it also does another thing. We talked about pain being a sort of a sensory and an emotional thing. And it also says to the patient that they understand what they're doing, they understand about pain, and they're sort of, they're telling us that that's going to make it effective. So there's the sort of the emotional psychological sort of input as well. But it does work, and it's certainly something. If you've got those patients, you think it might be a hot pulp, hyperemic tooth, then it's worth doing. But also, just go back one on that actually. But also, what we find is we because the extra excitability of the nerve, we need to block a longer length of nerve. We sort of remember back to sort of dental school with the sort of nodes of Ranvier with the sort of the synapses and the sort of the nerve sort of boinging along. And we basically put our nerve block in, and the hyperexcitability means that it goes sort of over the top of that. So what we've got to do with some of our anesthetics is block a longer length of nerve. So we might need a different technique that gives us, you know, the ability to block a longer length of nerve. So not necessarily just putting it in the same spot. We shouldn't necessarily just be try again, assume it's us. Have other strategies. Now, one of the most effective things, and you don't often need to do different sorts of blocks and things to sort of to block the longer length of nerves, because what I do is I always give more than one anesthetic. There's a lot of studies that have looked at this. And it's about splitting the dose of your anesthetic. So in the sort of the lower anterior region, you would do your buccal infiltration, and you would do a lingual infiltration as well. That's not the same for posteriors. In posteriors, if I've got a lower tooth, then I will always do an ID block, but I will also do a long buccal, and I will also do a buccal just distal to the tooth that I'm treating. And the reason for that basically is accessory innovation, but also you just find that you get a much more profound anesthesia in doing that. And I always do it. You know, as routine, I like to, I sort of see my treatments in phases, and my phase 1 is basically get my history and diagnosis. Phase 2 is then good anesthesia, because I don't necessarily want to be coming back to that. I want to get my anesthetic right, and then move on to the next phase of my treatment. So good anesthesia is really, really important. So I do give sort of three types of, three anesthesia for a lower molar. And I will use articaine for my infiltrations, and I'll use lignocaine for the blocks. Now, what we've said before is we need to block a sufficient number or a sufficient length of nerve. And here we've looked at this statistic here is it needs to bathe at least 3 nodes of Ranvier to block the transmission. And that's a sort of an enough of a length of nerve. And we should know our anatomy. We should know where that sort of foramen is that we're aiming for. So we need to analyze the anatomy of the patient before we deliver the LA. So we look and we palpate for those anterior and posterior borders of the ramus, and we should know where that sort of that foramen enters the skull. It's 1 to 1.5 centimeters above the occlusal plane, with an average of 16.5 millimeters from the anterior border of the ramus. But we should know our landmarks. We should know where the raphe is. We should know where the coronoid notch is. We should know how to sort of to deliver our local. So we should look at these anatomical points. So we should be able to palpate the sort of the posterior border and the anterior border, and know when we deliver our local whereabouts we're aiming for on the skull. Common problem with blocks is they're quite often too low. So there are other techniques to sort of to supplement our anesthesia, or actually deliver a slightly higher block. And again, that's to allow us to if we've got a really inflamed pulp, to deliver sort of our local to block those nodes of Ranvier. So we've got other techniques. We've got Gaugates and Akinosi techniques. The one I would sort of be mindful of is, which I think is more relevant and more useful, is the Akinosi technique. It's a closed mouth technique. And what you're trying to do here is deliver the local. And again, you need to know whereabouts that is on the skull. But it's a closed mouth technique. So that's useful if you've got sort of a limited opening, or if you've got a patient also gags. So sometimes it can be your first line of treatment. But it's deposited above the normal location for an ID block. You palpate the anterior and posterior border of the mandible, and you find the midpoint between those. And your needle insertion is parallel to the maxillary occlusal plane at the level of the mucogingival junction of the maxillary second molar. Now you need to work out exactly where the needle is going to go and where that's going to deposit before you do that. So you work it out on the outside of the face before you then sort of move in. And then you, because it doesn't touch an anatomical landmark, and then you you deliver the local. And the needle is beveled 15 degrees before you you insert it. But again, another technique. I actually don't often use these techniques. I don't find you need to if you do the supplementary anesthesia. I think that's something that you should be doing, and that works really, really well. One thing you do need to do sometimes is an intrapulpal. Occasionally you'll have that sort of case where you've still got some sensitivity when you're going down into the pulp. The important thing about an intrapulpal anesthesia is you can't do it if you're unroofing the pulp. So you need a tiny, tiny, tiny hole. And what you do is you then inject through that little tiny, tiny hole in the pulp roof. And what it's doing is it's creating pressure. And the pressure basically constricts the blood vessels. It stops the nerves transmitting. So it's not the local that does it. You could do it with saline, but obviously we do it with our local anaesthetic. But then you've only got a limited amount of time, because it's a pressure response, to get in there and do what you need to. You've got in truth about 20 minutes to do the treatment. And basically, yes, beforehand you should be warning the patient, saying this may be sore, because it is when you do it. Shouldn't be needed very often if you're doing the supplementary anaesthesia that we've talked about before. The next one, and this is a useful technique, is interpapillary. It's useful because it gives quite profound pulpal anaesthesia, and this is the one where you inject into the papilla, and as you go, you you deliver the anaesthetic. Good technique, and something that's very useful for delivering good pain control. So a vital part of managing our pain is knowing where our canals are, knowing where where the root canals are located, and therefore we have to know our tooth anatomy. We use our radiographs to predict if we've got sclerosis and stones present, and you should know where you think the pulp horns are. We've got a couple of slides here just to demonstrate and just to show where the canals are located. So this is the maxillary canal location one, and what we can see here, and this is the notable thing, is how little there is in the distal half of teeth. And I will always say, when I'm teaching dentists, I will say, well, I will find the mesiobuccal canal and the palatal canal in an upper six, and I will draw a line between those two, and they will explore the distal from that. So it'll get the anatomy, find those landmarks underneath there, and then I'll move towards the distal to locate the distal buccal canal. Because a lot of dentists start looking too far distally, and then you tend to stand more chance of going through the floor of the tooth. So understand where those locations are. And again, here we're going to look at the mandibular canal location. Here we go. And again, same comment. They're more mesial. They're less there's not a lot further. If you look at the lower molars, further back from the midline. The next thing is something I'm very, very keen on, and this is pre-treatment fillings. I've highlighted this not because it's an ideal case, but it's a case that I did years and years and years ago. And what I do a lot of the time, I use two materials to do this. I'll either use a glass armor or I'll use a SDR composite. And in this case here, we actually used a glass armor, which was Fuji 9. And what we're doing here is, so the patient presented in pain, and what I was trying to do was then open it up, extirpate that tooth. But one of the problems that you have is that when you put a medicament inside there, then that medicament would just flush out all over the place. And obviously that's no good. So you use a pre-treatment filling to sort of to shore up all the tooth, and then it gives you a nice reservoir and a well to sort of to work in. And this guy obviously had this wisdom tooth. He wasn't going to have the wisdom tooth out. He didn't want the wisdom tooth out. It got decay on the lower 7, and actually that's about 5 years between the one on the left and the one on the right. You know, so you'd have to say it's non-ideal, but it's a good result for the patient. And it's just something to be aware of. Pre-treatment fillings I do a lot of. I had today at about 3 o'clock. I had a young girl in, and she got decay on a lower 6, and we were doing a root canal on this tooth, and it was quite extensive, extending mesially. So you remove all the decay, clean it all out. She'd been in pain. It was got some swelling above it. So remove all those bits of decay. Put I used an SDR for her. Build that up with composite, and then you've got a nice easy treatment. Next time you haven't got to worry about restoring, because all you've got to do is just restore the occlusal hole. So it makes your job next time much easier. But really good thing to do. What I basically do is I just remove all the sort of the old restorations, broken bits, and then when I've done that, then I put a matrix band around it. I fill it with glass enomer. I put a little pledget if there's an exposed canal underneath there, and then just build it up, and then just re-access through it. I've got an example here. This is one I did a while ago, and this is just a big old amalgam, big MO amalgam, stained. It's a bit of a mess around there. Now, if I access that and I just go for an occlusal access on that and leave the filling that's there, the most likely reason that tooth has failed is microleakage. Now, if I leave that tooth there, if I leave that filling there, then I'm basically saying that I'm leaving those bugs there to get back into my root filling, which I don't particularly want to do. So why would I not remove it? And why would I remove it later on, but not do it now? So my technique on this case was, this is SDR, rubber dam on, and I'll put a little matrix down there. And SDR I use because I can then sort of paint it up the wall. And just leave that sort of on the wall, and then access into the tooth. Nice and easy, nice and clean, and it's really easy, to be honest, and it does a good job, and it prevents problems later on. It prevents inter-appointment problems. It means that I'm cutting down on the amounts of surgery time which I need, because I haven't got as many patients coming back with failures because the dressings failed. So something to think about. I'm not going to sit on this very long. This is then what we do when we found those pulp horns is basically we can unroof the pulp. Non-end cutting burrs, yes. Use your radiograph to give you the information. Use another PA. Don't just use one for angulation. And then one little tip, I use loads and loads of these, is use little micro openers. I use the size 10, and use your rotary files to open coronally. Hypochlorite, yes, when I'm doing my extirpates, I am using hypochlorite. I use copious amounts of it. It's a bacterial thing. So what do we need to do? We need to get rid of the bacteria. So how do we do that? We use hypochlorite. It's the most widely used. It's a very effective antimicrobial. The really good thing, it dissolves those pulp remnants up, used in concentrations up to about 6%. You can increase the temperature. You don't really need to. The higher concentrations aren't necessarily more effective, but you do need to be using above 2% solution. Why? Well, if you look at this little video, this sort of explains it. This is a full strength hypochlorite on the left and a 1% on the right. And if you watch what happens, then you can decide which one of these you would want your hypochlorite to do. This is pulp tissue. And if you look at the one on the left, that pulp tissue is gone in a few seconds. And the one on the right, there's no change. So those are the problems if you don't use one that does have this sort of the chelation. So we'll click on from that though. And then the other thing that we need to be doing is agitating our chemicals. Don't just leave them sitting there. This is an endoactivator. This is the lazy man's tool, and just goes into the canal, and it uses sonic waves to sort of to blast the sort of the hypochlorite throughout the canal. One of the things that we've got to sort of think about is one of the things that can cause pain is residual tissue. So we're trying to basically make sure that when we're cleaning out our root canals that we're getting rid of those bacteria, we're getting rid of the residual tissue. So we should be using our some form of activation of our chemicals. Now, activation of your chemicals can be done with a piece of GP just going up and down, up and down, up and down. And that's basically doing something very, very similar, but we should be activating our chemicals. And then this is quite an interesting thing, which we've discussed sort of more about recently in endodontics, and that's pulpotomy versus a full pulpectomy. It's very good. It does depend on a really, really good history. Understanding how your patient's presenting and where the bacteria are is absolutely vital, because what you're doing basically is you're saying, if you're going to do a pulpotomy, in other words, you're just going to remove the coronal pulp, it's got to be that the bacteria are only in that area. And so if your patient comes in with what sounds like irreversible pulpitis symptoms, but they haven't progressed, in other words, those bacteria are in the coronal, but they haven't migrated apically. So if your patient starts coming to you with saying it's tender, then this isn't a treatment that you can be doing on that, but it's something to consider. So think about where the bacteria are, but you must be able to control the bleeding. The bleeding should be controlled within up to 10 minutes, really. And what you do is you access it, irrigate with hypochlorite, you get a cotton pledget, and you place it on the bleeding area, and you put pressure on it, and you leave it there for 2 minutes, and then you take it off, and then you repeat it. What you do first of all is you clear away all the coronal pulp, and what you should be left looking at is pulp sitting over the orifices, like we see on the picture here. And then what we do is we put a bioceramic over. I use MTA. But the other thing you could use is something like biodentine and sit that over those orifices, and then restore with some sort of glass armor over the top of that. So definitely something that we should be bearing in mind as a sort of as a treatment option, and something that works really, really well. So it's something that I do on a number of occasions, and it's actually works really, really good. So now thinking about other treatments that we do, and the most obvious one here is extirpation. Rubber dam, yes, absolutely, should be using rubber dam. For me, rubber dam goes on at the start. I think, you know, in a post-COVID world, I think that's also accepted to be the sort of the best way of doing things. We're supposed to be minimising the sort of the effects of the aerosol. So getting the rubber dam on at the start is good practice. A lot of people used to say, well, why don't you sort of, you know, access first and then put the rubber dam on? I want to see where I'm going with it. But you can see where you go. You can get those landmarks and then access. And I think at the moment, it's a case of get the rubber dam on. I've talked about pre-filling, so I'm not going to touch on that again. And then we access the root canals. And then obviously, you know, in this COVID world, we've got, obviously we're doing an extirpation at this stage. We're full AGP. So you've got long sleeve gown, visor, FFP3, etc. And then we use long shank burrs for access and use hypo above 2% solution. And that's something you would use before you go anywhere near the root canals, because you're cleaning out the site of where the bacteria are. So those are nice, easy to get to bacteria that are in that area. And what you don't want to do is then to be shoving those nice, easy to get to bacteria into more difficult areas. And at this point, you kind of need to make a decision. And the decision is, are you going to do a full extirpate, or are you going to just remove the coronal pulp and then medicate? Because what you shouldn't be doing is do a half and half, where you sort of tickle into the root canal a little tiny bit. You'd be better off just either removing the coronal pulp and then dressing, or doing a full extirpate. And if it's necrotic, then unfortunately you are going to have to get in there and get the bacteria out from the entire root canal system. But if it's vital, then you can control that bleeding and then medicate and then book the patient back in, and that will normally look after the symptoms. Okay, so we've talked about this a little bit now. So understand where the bacteria are, and that depends on the diagnosis. What we're trying not to do is push the bacteria into more difficult to get to areas. Don't concertina up those little bits of pulp tissue and sort of shove them further into, which gives us problems further later on. We've talked about one of the aims of treatment being to aid our treatment later on. So you know, that's one of the reasons we want to get those chemicals in early. So do get your hypochlorite in when you've got your extirpate. No endo talk should be complete without mentioning Schilder. We should always think about what principles we're trying to achieve. We're going to talk in a minute about pain in between appointments and sort of and why that occurs, and that's often down to things that we do along the way in terms of damaging the sort of the anatomy at the apex, pushing things through, procedural errors that we sort of that we do, and that's because we're not observing the sort of the 5 pillars that Schilder described in his sort of ideal root canal preparation. So those are: maintain the original anatomy. So the canal should get narrow as it goes from the top to the bottom. It should have a smooth taper as it goes from the top to the bottom. The end of the canal should be in its original position and not moved. And at the end of the canal must be as small as practical. And this is quite relevant in terms of post-operative pain, because sometimes what we're doing is we're over-opening up that apical end and we're shoving irritants out into the tissue, and then we're causing flare-ups later on. So we must respect the anatomy and think about Schilder's principles at all times. And then we're looking at improving access. Well, there's a couple of things you can use: your rotary system files or Gates Gliddens. I don't like Gates Gliddens used as anything other than an orifice opener, because it normally involves damaging root canal anatomy and not meeting Schilder's principles. But we need to be doing some form of coronal preparation before we're doing any sort of measuring of working length. And at this point, we're looking at the straight line access. And in this case here, this is often one of the areas where we get problems. So looking at the diagram here, as we introduce our file into this difficult to get to area, the sclerosis occurs from the buccal in. And what you get is these tiny little areas where the file is basically deflecting down and towards the buccal side before it goes down. And so it then doesn't want to progress further down. So we need to be doing some coronal preparation to enable our medicaments to get into the root canal. But also, it prevents errors as we go along. If we've got these little constrictions, what the constriction does is the constriction stops the tip of the file, so that the coronal part stops the tip of the file sort of finding its way down the natural anatomy of the root. So straight line access, really, really important, and something that we should be looking at, you know, at these appointments when the patient's been in pain. We do the extirpate, you know, good straight line access, coronal preparation, and getting those chemicals into clean all those areas. Problems. Well, poor extirpation can cause a lot of problems. The main thing we're looking at here is blocked canals. That previous slide that we've just looked at, those canals would have been very, very easy to block, because as that file was dropping into that canal, what it's going to do is it's going to create a little ledge on the wall. So we need to do those coronal bits of opening to stop that blockage. And the other thing that we tend to do is, because we're rushing, is we use big instruments too early. So again, what we're talking about is concertinaing up those bits of pulp, and also just creating blockages, taking debris down into the apical areas. So try and avoid doing that. Instrument fracture. Instrument fracture is normally using an instrument too soon. So using too large an instrument, using a rotary instrument too early before we've created an effective glide path. Glide path is something we're going to look at in a couple of seconds, and something that's really, really, really important to establish. And then inappropriate instruments, things like SX files, and we're using those, and it's the tip that breaks, because we're trying to get the instrument to work where it's not designed to. So in terms of preparation, well, it's a chemomechanical debridement. So what we've got to think is we are giving access to our chemicals to the bacteria. Most of the bacteria, the highest concentration, are in that coronal area. So clean those out before you try and sort of instrument further down into the tooth. And then again here, we've just mentioned about glide path. All rotary systems require a glide path before you shape the canal. Don't place a rotary file into the canal without a glide path. And it enables that tip to advance without sort of having to make its path. Dressing, 99% of the time it's calcium hydroxide, and then a pledget, and then glass enema. And the last little bit we're going to talk about a bit more briefly is patients with pain between and after treatment. And this covers sort of immediate pain after treatment and pain sort of between treatments, and reasons for this. Yes, we can all expect sort of some mild pain, and that's common in endodontics. It's the severe pain that we've got to worry about. We've got an incidence here of 1.6 to 16%. Pain control, always advise it. We've talked about central sensitization and giving them ibuprofen before we start, but also we've then got to talk about pain control afterwards. So I will advise my patients, I will always say to them, it's going to hurt afterwards. And I'll over-advise them, because if you over-advise someone, they're warned. If they go home and suffer pain and then you say, yeah, but that was expected, then it's an excuse. So make sure you advise them. And also the anti-inflammatories are going to help. Ibuprofen is the best one. It's unpredictable. We do know, and there is sort of a direct link between pre-operative pain and post-operative pain. So those patients that have got pre-operative pain are more likely to have post-operative pain. And often endodontic pain, it can be okay for a couple of days, and then it gets that sort of builds up for a couple of days, but then normally quite quickly it tails off. But this isn't a need for antibiotics. The reasons, it could be that you've left the filling high. We've mentioned residual pulp tissue, so we haven't irrigated out and got rid of all those areas. We talked about activating our chemicals. We could be over-instrumenting or perforating. We talked about Schilder's principles, and this is extrusion of irrigant or dressing into the apical regions. And there might be an extra canal that we haven't located, we haven't found it. We might not look for it. We might not sort of know where our canals are. And we looked at those those diagrams and understanding those. Well, flare-ups, they're tenderness, and it's normally due to over-instrumentation. Phoenix abscess is a phrase that you sort of come up against, and it's an undesirable occurrence, and it's an acute exacerbation of an existing chronic condition, basically. And the reason people say it happens is it's just basically changing it's activating the bacterial flora basically within the root canal. And in this case, I would be getting that patient in and cleaning out that again. What causes them? Well, there's a number of reasons why they occur. There's microbial factors, effects of chemical mediators that are released, psychological factors for our patient, talks about those emotional inputs, and then changes in local adaptation. What that means basically is you've got an irrigant or something that's sort of gone into an area and it causes a severe localized reaction, and that gives the sort of periodicular injury that causes the pain. The chemical mediators, they're basically produced as a result of bacteria in the root canals. They produce endotoxins, and that results in pain. Treatment. Well, most of these cases involve getting the patient back in, cleaning out again, and then redressing with calcium hydroxide. Not giving antibiotics, but getting them back in and cleaning out. And I always get my patients back in and I'll redress and make sure that those symptoms are going to settle down before I complete. Just a quick word about antibiotics is basically saying, don't give antibiotics as a routine, and redressing is much the better option. Only would I give an antibiotic if there's swelling present and you're not going to instrument the tooth. Let's say you've got a retreatment case. And there's not time for you to remove the old filling, and then antibiotics, yes, are appropriate. I'm just going to mention the whole COVID thing and sort of our return to work and how we sort of work now and the changes that have sort of occurred. This is a document that was produced by the British Endodontic Society when we were getting our practice back working 5 weeks ago now. We looked at a lot of operation procedure documents, and actually this was one of the best ones and one of the easiest to understand documents. This is generally available. So if you go onto the British Endodontic Society website, this is something that is there. It's a really, really good document. It's color coded. The blue ones are basically requirements. And then there's advisory and clinical judgment. The advisories being the green ones and the clinical judgment being the orange ones. And these are things that you have to do for your patients and your clinical staff. But there's some really, really nice little diagrams in here. And actually, it's really too easy to understand. And we've got these up in some of our surgeries. This is the surgery one and the sort of the how the surgery flow works. And then after treatment one for patient and clinical staff. And just a really, really easy to understand and really well written document. This was the treatment protocol, and this was the recommendation that was put out at the end of June. Isolation, use of dental dam mandatory, ideally single tooth and placed prior to access in such a way that the entire oral cavity is covered, and using of corking. Access into the pulp chamber, limit AGPs to the start of the appointment to minimise that lovely hour that we all have to observe. Removal of the restorative material, access with high speed, avoid the use of the 3-in-1 as much as possible. And then it basically goes into the details of the extirpate, completion of root canal preparation with preferred file system, irrigation, and basically do as much as you can in as few appointments as you can is what the document is saying. Dry the pulp chamber, and then dress, and then we can then go on to obturate. We don't have to wait for the next sort of phase of reopening because we're minimising those appointments. So it's just to sort of to highlight that document really, and just to sort of if people are not back or if they're still sort of developing their sort of protocols, have a look at that. It's an excellent document actually. The good news for everybody is that's kind of where we are. In terms of we're kind of done. So I'm just going to have a look and see how many see any questions. So the first one is, if the patient has a periapical radiolucency, is it appropriate to do pulpotomy without using files in the canals in the emergency appointment? Any cleaning's good. Pulpotomy here, you're going to have necrotic tissue in there. So in that instance, I would be trying to get my files in there and clean it out and then put some calcium hydroxide inside there. Any cleaning we do is good. But in that situation, I think we've got necrotic tissue. I'd be wanting to sort of get in there with my, my hand files. The next one is, how would you make a Lucia jig? And how would you instruct your patient to use it? How would I make a Lucia jig? I actually use DNAR deprogrammers. So you buy little DNAR deprogrammers, and you get these little balls basically, and they go in boiling water, and they basically they basically become homogeneous lump, and they go into the little deprogrammer, and you just sit that over the front 4 teeth, and you wait for that to set, and just in and out, in and out, in and out, so it doesn't sort of get locked into any undercuts. And then what you're doing is you're basically then going to just get a little Gothic arch trace. So you'll get one of your teeth, one of the lower teeth, to then sort of carve in a Gothic arch trace onto that. So just get your patient to grind forwards and backwards, and then to the left and to the right, and you should get that little crow's foot appearing, which you just grind in onto the bottom of the Lucia jig. And then I tell my patients to wear it at night time. Very, very simple. It's 5 minutes to make a Lucia jig. and much easier if you use those little DNAR deprogrammers. So look those up. So DNAR deprogrammers, very, very good. If the tooth gets symptomatic, is it hard to remove the MTA or Biodenti? Okay, so this is if you're, I presume that this person was meaning if you have a situation where you've done a pulpotomy. You're not filling the root canal with that. You're leaving the sort of the pulp stumps, so to the orifice, and then you're filling. So in terms of getting back to it, you can just drill through those quite easily. So you're not filling all the way down into the root canal. That picture that you saw with the sort of the pulp stump, the sort of the orifice sitting there with the sort of the with it sort of stopped bleeding, is exactly where I would be sort of leaving the tissue at that point, and then putting the little bit of MTA or Biodentine over the top of that. This is another same one, same question. Is it easy to remove the Biodentine MTA from the chamber? Same answer. So yes, it's really easy because it's not, you're only using a couple of mil, couple of 3 mil thick of material, and then glass ionomer above that. What dressing do I use after pulpotomy? Well, I use MTA, and then I put a glass ionomer over the top of that. What medication do you use after pulpotomy? So again, MTA for me, Biodentine. It has to be a bioceramic. What would you do? This is a good question. What would you do if a root-treated tooth is fractured, exposing the root filling, been left exposed for weeks, but no pain on presentation? Would you do the re-RCT before providing a new filling? Right. Well, this depends on which side of the fence you sit. Looking at the literature, there's lots of different studies. In fact, the Endodontic Journal won't let anybody do dye studies anymore, because we've got studies ranging from 3 days to 42 days in one study that I can remember, in terms of when infection. That was a Madison study. That was and that's when it becomes infected again. So what I would do in this situation is, if it meets the requirements for a good root filling, then if it's within 2 mil of the end, there's no signs and symptoms, and it's well condensed, then I would put a provisional filling in there, and I would monitor it. So I would do a sort of a filling and leave it 6 months, and then take another PA. And if they've not got pain, then I would be fairly happy to sort of to put a more definitive restoration in there. So good question. It depends on which bit of literature you read as to whether you believe that it will have infected or not. I certainly wouldn't be jumping in there. If the patient had got no symptoms and no pain, then I wouldn't be jumping in there and saying, oh yes, yeah, I'd definitely go and remove it. I think that argument might change if I was then going to put some really, really pretty ceramics on it. And then I would have to look very, very hard at the quality of the root filling and how long it's been exposed. But if I was just doing a filling in there, no, I'd then monitor it. And even if I was going to put some ceramics on, I would then probably say, well, we'll hold off on these for now and see how it goes. With periapical area and root treated non-vital, with periapical area and tooth non-vital but asymptomatic, when do you recommend RCT? Patients not having any pain or discomfort. You don't want to leave infection that's there, basically. So I would be saying, get in there and do your RCT. It's unpredictable. I mean, all we can do is explain these things to our patients. I mean, if the patient chooses not to have treatment, I do a lot of consultations for the patients that are referred to me. Do those patients always return? No, they don't. And that's okay. We can give them the information that we can give them, and we can give them the benefit of our knowledge and tell them, that's why we're understanding what the bacteria are. We say to them, there's loads of bacteria there. there's going to get more strains of bacteria. There's going to be more bacteria. It might flare up. We don't know. It's unpredictable. But that's all we can say to our patient. I mean, ideally for us, we get on with it. You know, if it's got a periapical radiolucency and it's non-vital, we know what's wrong with it. It might have been there a long time. So, you know, that's something that we need to sort of, you know, think about. We've got another one here. It said, in an RCT treated case, underfilled but no periapical pathology, do I need to re-RCT before an indirect crown? Depends how underfilled it is. If the obturation is not very good and you are going to put a crown on it, you kind of own the root filling if you put the crown on it. So, you know, in that situation, if the quality of the root filling isn't where you would want it to be, then I think then yes, you would have to consider refilling it, and you're going to put ceramic on it. The other option you've got is not to put the ceramic on, leave the ceramic on that's there at the moment, if there is one there, and then put a provisional on. If there's no change in that sort of, and then review it. One thing that I sometimes recommend my dentist to do, if there's a case where I've done a treatment, I might not have been able to get everything that I want to out of the old, you know, if there's been a fractured instrument that I couldn't quite get out, if there's been an old root filling material that I couldn't quite remove, then I might say to the dentist, well, do some sort of capped cusp direct restoration. So something that, you know, they can do, so sort of to the cap over the cusp to decrease the amount of pressure on the tooth. And then I'll review it in 12 months time. So, you know, we're thinking about biologically that we're protecting the tooth, but what we're trying not to do is commit that patient to sort of, you know, obviously more costs and further things along the way. So I think we've just got to be a little bit sort of careful. But if that, you know, if that case hasn't been very well obturated, then you know, in those situations, you know, you're not meeting those requirements of having a sort of, you know, well obturated and no signs, symptoms, no PA radiolucency. Antibiotics, which antibiotics? Well, my standard one I would go to is amoxicillin, 500 milligrams, and that's the first line of sort of antibiotics that I use, or metronidazole 400 milligrams, people that are allergic to it, 3 times a day. If you plan to do a retreatment on another tooth, would you use any solution to dissolve that GP? Or would I use an instrument to remove the old GP? You can actually do either. I use rotary instruments to get rid of a lot of the GP. You can use anything from sort of, you know, profiles are actually quite good still for getting old GP out. You can use files from your rotary systems, F2 files from ProTaper sequence. And yes, you can use, you know, there's eucalyptus oil type things to dissolve it up. And I've used eucalyptus oil, and it does seem to, you know, to do something. Sometimes when you get that last little bit, and I don't want to put my file, my sort of rotary file in there anymore, because I just want to gently just work through, because I suspect there might be a little bit of a blockage there. Then that's the time that I would use some solvent, but we use solvent less and less. There are retreatment files, obviously, which you can also use, but, you know, retreatment, it's I think now we're using less of the solvents and more of the sort of the files than we used to. I think that's pretty much it for those questions. So there we go. Right, well, I think that basically wraps us up, really, and sort of. So I hope I've answered and given you some information that you've found useful, and that you know, you'll take some things away from our talk. And in the meantime, stay safe, and thanks for listening. Thank you very much.